This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, John is going to be sharing a soon-to-be, I'm sure, landmark paper on using injectable buprenorphine in pregnancy. So, John, how are you doing this evening?
I'm really enjoying a nice rainy night here in my office, like half asleep after clinic. So, in this beautiful South Central PA, the second version of spring, or the second wave of spring before winter hits again here.
Right. So, for any of our listeners, it's like 9 p.m. right now at the end of April. I don't know when this episode will air, and John is still at work. But yes, it's a beautiful rainy night. I'm doing pretty good. I just came back from ASAM conference, American Society of Addiction Medicine. I had a great time, and I just have to highly recommend that everybody go to a addiction medicine conference occasionally. It's very invigorating. You feel a real sense of community. The food was really nice. So good work on that ASAM. And I ran helped run a workshop on benzodiazepine tapering, which was really fun. John, have you ever been to ASAM? Well, I know you've been to ASAM. What have you thought about when you went to ASAM last?
I really liked it. I mean, it was a lot of content. I like the networking. I'm going to be honest, I'm a little spoiled as like a primary care doctor. A lot of times they bait us into really fun conference locations where like our conferences are like from 7 till like 1, and then I get to hang out like with my family at Disney World. It's very different. It's a very long day at ASAM, right? I mean, it starts at 7. I feel like you're still grinding at like 8 at night.
Yeah, but they're not messing around.
They aren't. That's real. There ain't no Mickey Mouse ears there. So it's good though. I mean, I really enjoy it. I feel like I wish I would have went with you.
Yeah,
but,
next year.
Yeah.
Where is it next year? Did we look that up?
I thought we did. Is it LA?
No, LA's well, I don't know if it's in LA. Maybe it is. I'm thinking of going to an LA conference in 2028.
Oh, okay. Maybe that's where I heard that from. Oh, Minneapolis. Oh,
ooh.
Sunny Minneapolis. Oh, Seattle's the year after. That'll be fun.
Yeah.
And then back to Baltimore. No, that'd be topic relevant.
Yeah, we got to go to Baltimore.
Yeah, we'll be there.
Yeah, we'll definitely be in Baltimore. So, John, anything strike you in addiction medicine news this week?
This wasn't really news, but I read this really kind of interesting opinion, and it's from First Opinion from Stat, and it's called How the Insurance System Quietly Undoes Recovery from Addiction. And I'm not sure, have you noticed that patients navigating insurance have caused issues with recovery for your group?
Some. It's usually the private insurance is the big issue. Our state insurance is amazing, but once you go on to private insurance through your job, suddenly your treatment has to change.
Yeah. Yeah, I mean, exactly. I think that's exactly what I see. And, this article was very interesting. A couple of key points. They talk about a nameless patient who basically risked relapse because they changed insurance carriers, and their monthly prescription for their medication increased from $40 to $138 a month, which was no longer cost prohibitive for it. They talk about oftentimes we stigmatize patients as like, their relapse is their fault, and we start to not think about systemic issues. And certainly we're very aware that things like social determinants of health, housing, psychosocial stressors are problems. But I think it's tough when actually the insurance is actually the problem, right? So a lack of access to a medication that was previously working. I think you're incredibly correct. I see a big change when my patients go from state to private. It seems like it's almost a setback in our recovery, and kind of it is a big hurdle for them to navigate that kind of potentially risk destabilization. And, they really kind of actually refer to, I like this quote, the quiet relapse engine of this kind of like refill system. And I thought that was a very elegant way of placing this. And so I think the article just kind of points out an issue that I think we see every day, that changes in insurance and changes in coverage really jeopardize patients getting the care we want. And I know this is an addiction podcast. I feel this all day, every day for everything. I'd rather prescribe an SGLT2 inhibitor, but I'm prescribing, a sulfonylurea for diabetes, which is a cruddy drug because it's cheap, as opposed to the other one that's really expensive. But a patient can't afford $600 a month for a prescription, and I can't blame them. I'm a doc and I can't afford that. So There's a great article. I had this idea one day that and this might be my like side gig to cash out. I'm gonna make a board game, sort of like Candyland, and it's gonna be called
Uh-huh.
Recovery. And one of the spaces you land on is like 2/3 the way through. It's like you just got like private insurance, go back 5 steps. But it's gonna be
Yeah.
like one of the things they have to navigate to get through because it is often very challenging. And, I feel like I spend so much time dealing with private insurance, particularly with authorization at this point. It's absolutely, soul destroying for me as a primary care doctor.
Well, it's this really hard time for people, and I see this not just in healthcare, but we see it in other areas too. If you're very impoverished, you don't have a lot of resources, you rely mostly on state benefits, you can get a lot covered. You get Section 8 and food stamps and Medicaid and all these sort of benefits. And then if you try to, better your situation, you go back to school, you get a slightly better job. Suddenly you lose all these benefits, but those initial jobs are not that great. And so they
Yeah.
don't pay you enough to afford rent and food. And then the insurance is private, but it's not very good private insurance. So like your your kind of living situation or your resources actually go down as you go from like not working at all or working at a real minimum wage job to something slightly better. And then you have to work through that up to having a job that's good enough that you can actually buy these things again without benefits. So that's a very hard time for people who are trying to kind of be upwardly mobile. Um, and that's what I see. They get a good job. They're super happy they have a job with benefits. And then those benefits aren't that great and they don't actually cover what patients need, but they don't qualify for Medicaid anymore.
Yeah. How about you? Did you read anything interesting this past couple weeks?
Yeah, it's not really news, but it was more like a basic science article that I liked about opioid withdrawal and something called the kindling effect. It's in mice, so we're not going to present it, on the podcast as a featured article. But I'm really fascinated about how much we don't know about opioid withdrawal. Even though opioid withdrawal is like a driver of continued opioid use for many of our patients. So if you're not familiar with the term kindling effect, but it's usually seen more with alcohol and benzodiazepine withdrawal, but it means repeated withdrawal episodes become increasingly severe over time. So both alcohol and benzodiazepine withdrawal is due to upregulation of these excitatory glutamate transmission, and then it's unopposed when you stop the alcohol or the benzo. And with repeated episodes of withdrawal, it seems like that excitatory tone gets higher and higher, and then withdrawal comes on more and more quickly and stronger. But patients have reported this kindling phenomenon with opioid withdrawal as well, but it's just not as well understood and characterized. So these researchers had exposed mice to fentanyl. So the mice got 5 cycles of fentanyl and then fentanyl withdrawal. And with each cycle, the mice had increasing withdrawal behaviors and the withdrawals lasted longer. And then, so things like hyperalgesia, anhedonia. So they gave them like a water bottle full of sugar water. And in these anhedonic periods, they didn't care about the sugar water and they weren't interested in it. So that was like a sign of withdrawal. They had more anxiety. So they showed that, in this mouse model, this kindling effect was happening in terms of behavior. And then they dissected the poor mice and looked at their brains. And those who had had 5 episodes of fentanyl withdrawal had significant changes in the brain compared to 1 episode of fentanyl withdrawal, and specifically in the microglia. And they used the phrase massively altered gene expression towards this kind of pro-inflammatory state. Many fewer branches, many fewer connections with neighboring cells. So real significant anatomic brain changes that they could see with multiple episodes of withdrawal as opposed to just single episodes. So, the paper is open access. I'll put a link in the show notes, but I just thought it was really interesting. So like, John, have you seen the kindling effects with opioid withdrawal in your patients?
You know, I don't work in like an inpatient. I mean, I do inpatient consults, but I don't work in a detox setting. I think that would probably be the setting where you would likely see this the most. And it's hard. I feel like I think most of my patients just kind of talk about this profound withdrawal, especially in the fentanyl era. I have not heard anyone ever describe it as a mild sensation, right? So,
Yeah.
I mean, I would need some sort of like comparison on the lower end of the spectrum to kind of say that I'm seeing this more frequently or changes. But I feel like just in general, this withdrawal and getting through this tends to be the biggest challenge for a lot of people. And it seems like people are more aversive lately. So maybe subconsciously that's what we're seeing. I'm not sure.
Yeah, or maybe like I see people, they don't necessarily characterize it as the withdrawal is worse, but they say, I used to be able to stop, no problem. and now I can't. I just can't do it. So I don't know if that's a worse withdrawal or just some other change from prolonged use. But I just think it's a really interesting phenomenon. Up to Date is my work Bible. I love Up to Date. I'm not being paid by Up to Date, but if Up to Date wants to pay me to promote them, I'm totally there because I love them. But in all of Up to Date, they only mention the kindling effect once in like a single half a sentence in the alcohol withdrawal section. So it was barely touched on, but I really feel it does have a significant effect on people as they deal with repeated cycles of withdrawal. So I don't know. That's why this article struck me. I thought it was pretty cool. I'll put the link in the show notes. So, John, you ready to tell us about this amazing article you reviewed?
Yeah. Although one sidebar, with how much Up to Date jacked up the cost of that subscription, they have the money to pay you, Sonya.
Yeah. Up to Date, you owe me
Like
$50
doubling
for
that
that
cost.
plug.
That's
Yeah,
crazy.
I know.
Yeah.
But with
Anyway,
all this free information, everyone's like, "Oh, AI will find the information for you." Like that information is crap. And if you want like really good information, you have to pay for it. There's no free lunch. So I'm happy to pay good money for good information.
you're such an American.
Gotta pay for it one way or another. I mean, if it comes to my taxes, I'll pay taxes for good information. I'm cool with that.
All right. Yeah, so the article I was really excited for because this comes up often, and I'm glad to actually see a trial about it. It's from JAMA Internal Medicine from March of 2026. It's called Extended Release versus Sublingual Buprenorphine in Pregnancy through 12 months postpartum. It's a randomized clinical trial. A little bit of background here. So everyone knows that sublingual buprenorphine is standard evidence-based treatment for opioid use disorder in pregnancy. The gold standard would probably still be considered methadone, but sublingual buprenorphine is still kind of a heavy hitter in terms of treatment options here. Sublingual buprenorphine is associated with a lot of limitations. I think that there's a concern regarding diversion and misuse for giving people tablets. I've seen it. I'm not as concerned about it. I think adherence is a bigger concern that I have. And then also just these peak trial fluctuations throughout the day. It is interesting that when extended release buprenorphine came along, I will be very first to admit that I was drinking the haterade. I did not see a big niche for this high cost product. But with the stable drug levels, it's very advantageous for many of our patients. And because of this, we actually say in pregnancy and how the volume of distribution of drugs differ, those likelihoods of kind of like fluctuations of peak and trial actually widen to make control of withdrawal much more difficult. Not surprisingly, extended release buprenorphine for these reasons has demonstrated superior illicit opioid abstinence in our non-pregnant adult patients. Extended release buprenorphine does raise concerns overall for high drug exposure, though, however, because it's more time at that peak level and less trial, and potential increases in fetal exposure and possible teratogenicity. To date, evidence for extended release buprenorphine in pregnancy is limited to a couple case series and cohort studies with no RCTs to date in pregnant patients. So this is like a real area of clinical interest that hasn't really been developed in the current medical literature. So I think it's a really exciting area for something that comes up pretty frequently.
Well, and we really need this. I just have to say, we really need this trial because so many of our colleagues are using this in pregnancy, either because patients get pregnant while on this product and don't want to switch, or because they really think it's the best option. They haven't seen a lot of harm and they've gone forward with it. So tons of pregnant women have received this product. And we really need more data on it.
Yeah. How many times does this come up for you in pregnancy?
I have had 2 patients who wanted injectables but didn't get them because they were pregnant and they were not. I didn't withhold it, but they said, "Oh, well, maybe after my pregnancy's over, I'll do it." I haven't had anyone who got pregnant while on injectable.
Yeah. I've had 2 get pregnant while on injectable, and it raises a big question about what to do.
Did you switch them off it? What'd you do?
I mean, at the time, yeah, I did. I put them both on kind of monotherapy buprenorphine. And that's mostly because at that point, I mean, this was relatively probably over a year ago, the most recent one. I think there was even less people doing case series, and I just didn't feel comfortable with it.
Right.
Although now that I'm thinking about it in retrospect, it might have been nonsensical because that, you worry about, I'll get to it later on, but the drug depot's in place for quite some time. So I'm not sure how much it's really changed in exposure.
Right.
But it made me feel safer for some
Yeah,
reason.
well, and the moms also, they don't want to be destabilized, but most pregnant people are pretty sensitive to what might cause injury to the fetus, and if there's any chance, they do often prefer to switch to the least risky option.
Yeah. So, what is the clinical question? One, in pregnant patients with opioid use disorder, does weekly subcutaneous extended release buprenorphine achieve non inferior rates of illicit opioid abstinence compared to sublingual buprenorphine? And two, in pregnant patients with opioid use disorder, does weekly subcutaneous extended release buprenorphine result in improved neonatal outcomes, specifically reduced incidence or severity of neonatal opioid withdrawal syndrome compared to sublingual buprenorphine? And I'll be honest with you. I mean, the primary question here is about the birthing person. I actually am more interested in the neonate outcomes because I think that's my area of question mark. And I think we already know this product works well. It doesn't make sense why it wouldn't work well in pregnant patients. But I have the bigger, and maybe that's the family doc in me. But I am kind of more interested in the child's side of this.
Well, and as you said, that's the real unknown. I think there's no reason this would be worse in pregnancy.
Yeah.
Everything we know about pregnancy would make this, be better in pregnancy.
So this was a two-group, open-label, randomized controlled clinical trial comparing extended release versus sublingual buprenorphine in 140 pregnant adults with opioid use disorder across 13 outpatient sites from 2020 to 2024. The primary outcome was illicit opioid abstinence during pregnancy and postpartum, and that was assessed via weekly urine drug testing with secondary needle outcomes, including treatment for neonatal opioid withdrawal syndrome. There was 140 participants with opioid use disorder. They were all pregnant. Inclusion criteria was that they were 18 to 41, singleton pregnancy at 6 to 30 weeks gestational age. They met DSM-5 criteria for moderate to severe opioid use disorder. They were eligible for or already on buprenorphine. They planned to deliver at a hospital with standardized neonatal opioid withdrawal syndrome protocols. We excluded participants with physiological dependence on alcohol or sedatives that would require withdrawal management, significant psychiatric or medical conditions limiting safe participation, current or pending legal issues interfering with participation, receiving methadone or naltrexone, and planned higher level of addiction treatment beyond ASAM level 3.3. A little bit about the protocol. So protocol started with enrollment and participants were at week 6 to 30 gestational age. They are randomized 1-to-1 to extended release versus sublingual buprenorphine. This was stratified by site, gestational age, and prior treatment. Pregnant and breastfeeding participants in the extended release buprenorphine group, they only received the weekly injection. So as we all know, there's a weekly and monthly injection. I did not know this until I read this article, but the reason for this being is that, the concern regarding teratogenicity is for the excipient, which is this 2-N-methyl-2-pyrrolidone, which is basically concern for possible potential fetal risk. So, and the excipient is basically what the drug is bound and contained in within the monthly injection that allows it to depot and dissolve. So it has nothing to do with the active drug. It just has to do with kind of the binding and dissolving agent that it's suspended in. And that's only in the monthly injection. So this is devoid of the weekly injection.
Well, and that might have something to do with why the monthly injection comes on a lot quicker compared to the weekly injection, because it's a different. I sort of always assume they were kind of the same matrix, but of course it makes sense that they're not. And I know when we talk to people about they say direct to inject, where you just give an injection even while the person's still using fentanyl, you get less precipitated withdrawal with the weekly because it has kind of a slower onset compared to the monthly.
You think it would be the opposite because of the binding agent. You think would slow it down, if anything.
Yeah, but apparently the monthly is a real quick onset. And so
Alright.
can give people more precipitated withdrawal. Sorry. Anyway, digression.
A weekly injection is something to date, I will go on the record, I've never used. I've questioned the utility of until now, but here we go. Here's the use for it. They were offered the monthly injection postpartum if they were not breastfeeding. During the pregnancy phase to delivery, they had weekly medication administration. Either they received their injections or they were given their medication to take home. They got urine drug screens. They had assessment for safety and adherence. There was research visits, 2-week post-randomization, and then monthly that were longer, looked at things like craving and withdrawal assessment. At delivery, they specifically looked at infant outcomes, particularly NALS scores, hospital stay, whether or not treatment for NALS were needed. They did maternal delivery outcomes. That was all derived from the medical record. Postpartum, from 0 to 12 months, they did continued treatment follow-ups. They did visits at 1, 3, 6, 9, and 12 months. They looked at substance use, maternal safety, and infant development. And they used the American Academy of Pediatrics ages and stages. Or no, not ages and stages, bright futures. I'm sorry. At the end of the study, 12 months postpartum, they did maternal and infant assessments. They looked at the primary outcomes of opioid abstinence, and they kind of reanalyzed for kind of like now score safety and development for those exposed infants to the buprenorphine in the two formulations. As we said, primary outcome was illicit opioid abstinence during pregnancy, and that was assessed via weekly urine drug testing. Missed samples were just assumed to be positive. Secondary outcomes was postpartum illicit opioid abstinence. Again, they did weekly urine drug testing. Missed samples were assumed positive. Neonatal outcomes were need for opioid treatment for neonatal opioid withdrawal syndrome. That was kind of a binary outcome initially, kind of yes or no. And then they looked kind of sub within that, whether or not the treatment required medication and what duration of treatment people received or the patients received. Maternal outcomes included treatment adherence, so proportion of days that people were on the treatment, and they did that through assessment of urine buprenorphine levels. They looked at opioid cravings with an opioid craving scale, withdrawal symptoms for a short opiate withdrawal scale. They did prenatal care utilization via this Cuddle-Chuck index from the medical records, which I think is a very patient-centric one as well, kind of plugging people into prenatal care is a big barrier here. Infant outcomes include now severity. They did the modified Finnegan, length of hospital stay, so that's days from the medical record, and they did developmental outcomes at 12 months, which was the ages and stages questionnaire. They did intention to treat analysis and regression analysis for the different effects. So what do you think of this trial so far?
Well, I love it. I really feel that there's not enough research in pregnancy. We leave a lot of questions unasked because we're afraid to do research in pregnant women. We want to protect them, but it's really nice to have a randomized controlled trial in pregnant women. It's a great trial. I think the question was good.
Yeah, so here's kind of like my assessment of validity of the trial. So the funding was provided by the National Drug Abuse and Treatment Clinical Trials Network, NIH, and NIDA, with Braeburn donating the extended release buprenorphine, which is Brixadi. So it was not industry funding, but industry did donate the product for use. When you look through the financial disclosures, multiple investigators reported kind of receiving NIH and NIDA funding, but also there was a lot of industry ties, including honorariums, speaking fees, and study support from Braeburn, Camaris, Indivior, Berkshire Biomedical, Journey, Colab, Gilead Science, Coco Medical, and Merck. And so there was some direct financial relationship between the drug manufacturers and kind of the not the design of the study, but many of the people involved with this study. Not that necessarily exhibits bias, but it's something definitely to speak about. Is a moderately sized open label RCT of 140 pregnant patients with opioid use disorder comparing sublingual and extended release buprenorphine. So it was randomized. They did try to match well. This was not blinded, so there's no sham Brixadi injections that were given. The author noted that the sample was mixed in representation. So they talked about the 13 diverse sites. A large proportion of patients were polysubstance at baseline. However, on the same token, they also comment about how they weren't that diverse, with 98.6% of participants were actually on treatment at the time of randomization. So that indicates that this was kind of a not intentionally selected, but it was a relatively stable subgroup in terms of our pregnant persons with opioid use disorder. I kind of appreciate the mix of outcomes here. So I think that it's funny, docs listening to this always want to hear things like UDTs for abstinence, now scores, hospital duration, ages and stages. I actually they added a couple other ones. I think the prenatal care engagement, that's a very patient-centric outcome, getting them involved in prenatal care, which can be a real difficulty. Ages and stages, I like that. It's some objective measure, even though 1 year is kind of short for that amount of time. Postpartum pain management, postpartum anxiety, those are huge patient-centric outcomes. So I think there was a nice mix here. I really kind of applaud them for that, since I feel like that's a common critique that we're stating about a lot of these other articles. The authors note that relying on the EMR data were likely to underpower results due to missing data. So it's tough. I feel like we're just so EMR centric anymore where like, if it didn't happen in EMR, it's hard to extrapolate if it happened at all.
Right. We've become unable to research things that aren't in the EMR.
Yeah, I mean, it's just a billion in data source, although it's tough because not to get too sidetracked, but I look at these EMR reports all the time and they're not always accurate for certain things, especially if it sounds too good to be true. If you actually dig into the cases, sometimes there's some missing or underrepresented data there. You know, I would love to see a follow up on this in terms of the infants. So, like 12 months, I appreciate that's a great start for this. A lot of our developmental milestones and kind of especially psychosocial, you really can't pick any kind of differences in them up until like age 24 months. That's kind of part of the reason why we have these controversies with vaccines, kind of because 2 is really the earliest age you can start to assess for some of these issues, and that has to coincide with the timing of our measles vaccine. So I would love to see this like another like 36 months of follow up on these kids, like as a follow up study. I think that'd be awesome, just to kind of prove still that these are safe medications in children as they develop after birth.
Yeah, agreed.
They might already have that in the works. I wouldn't be surprised if we got an email that they're already tracking those kids, but it sounds like a very easy kind of follow up here.
If you're tracking those kids, let us
Yeah,
know.
I would love to know. I bet you they are. So what are the results? In terms of the demographics, there was 140 participants, 69 in the extended release, 71 in the sublingual. Mean age was 31.2. 82.9% were white. A third of them were employed. The mean gestational age at baseline was 21.1 weeks, and 98.6 were already on buprenorphine treatment at baseline. So they were not kind of initiations or starts. In terms of study completion, 98% completed the study through pregnancy, and then 81% completed it to the 12-month postpartum mark, which I think is incredibly impressive. In terms of the primary outcomes, so the first one was illicit opioid abstinence during pregnancy, and not surprising, the extended release outperformed here. So 82.5% versus 72.6%, meaning that there was about a 10% difference that was statistically significant in abstinence for the patients that received the extended release product. In terms of postpartum abstinence, actually, there was really no difference here. It's 60.2% versus 59.5%. So no statistically significant difference. And it is kind of interesting. It just kind of shows you, I guess, like, when you have when people are parents to be, I feel like people really, really, really try to be the best version of themselves. They're really, really trying and, they want to do well for their kids. I think this shows it's a very high abstinence rate. And I think it also reflects that, when you have a baby at postpartum, it's a very stressful, difficult time in people's life. It's not surprising to me that that's a time where there's a little bit of a drop off there.
Well, it's also a time when a lot of like support could end. Like I think there's a lot of programs for pregnant women. You're seeing the doctor all the time, especially towards the end of pregnancy. You're going in like every week. And then as soon as you have the baby, a lot of that support kind of evaporates.
Yeah. In terms of the secondary outcomes, I broke this into by kind of like person involved with this. So in terms of maternal outcomes, so serious adverse events. So in pregnancy, there was lower serious adverse events in the extended release group. So it's like 8.7% versus 26.8%. In the postpartum, they were also lower in the extended release. So 6% versus 18.6%. And both of those were statistically significant. So in terms of serious adverse events, less common with extended release. In terms of non-serious adverse events, they were similar, but actually they were slightly more in the extended release during pregnancy. So it was 26.1% versus 7%. It was tough to really drill into that. I think we all know that a lot of the injection site reaction are pretty common. By far, that's probably the most common non-serious adverse event that we see with many of these. In terms of postpartum outcomes, there was less opioid pain medication use in the extended release groups at 30.2% versus 50%. And there was lower postpartum anxiety scores. So kind of like pregnant women, they had lower serious adverse events due to medication, less opioid pain use postpartum, and lower postpartum anxiety scores with the extended release product. So extended release seemed to win out here for mom. In terms of secondary outcomes for the infant, in terms of now opioid treatment requirements, so extended release was 30.2% versus 26.5% in the sublingual. So in both groups, about a third of the infants required treatment for NOWs, and there was no statistically significant difference between the two groups. In terms of duration of NOWs treatment, 10.9 days versus 14.8 days, slightly longer in the sublingual, but no statistically significant difference. And then in terms of other infant outcomes, there was no significant difference in hospital stay, morphine dose, developmental outcomes up to 12 months, and custody cases in terms of and CPS involvement. The only thing that was statistically significantly different was that head circumference at birth was slightly larger in the extended release group, 34 versus 33.4 centimeters. Both of those are in the normal range.
Hmm.
I actually think it was kind of interesting here that they kind of pointed that this was a concern. I actually feel like I've always been told, and I have to look that up. I should have looked that up before I talked here, but I should have. But like I've always been told by my developmental pediatricians that have kind of trained under that head circumference is like one of the best predictors of growth because it's kind of brain development and size. So I would think being kind of like higher normal would be better. But I'm saying that's just what I've been told in the past. So I don't think that's necessarily a bad thing for the extended release.
If you had up to date, you could look it up right now. Don't
I'm
keep
gonna keep
going.
that $800 or whatever it is this
Pay
year.
the $800. Yeah, whatever.
So kind of like summarizing here, in terms of abstinence, kind of it seems that the extended release definitely outperformed the sublingual, particularly during pregnancy than after pregnancy. Lower serious adverse events in the extended release group, less pain medication use, lower postpartum anxiety in the extended release group. Very limited to no difference in the infants exposed to either product. So I think, will the results help me in patient care? This comes up frequently. I care for patients both with opioid use disorder that are pregnant and after pregnancy, and often I'll take on the baby as well. A growing number of patients I have on these depot products. In fact, I felt kind of somewhat malignant or good or bad. I don't know how to feel about it, but they had to get a second refrigerator at my office just for my depot buprenorphine because it's taking up too much of the other locked fridge. So like I have my own fridge, which I'm like, yeah. And they're really expensive, like medical fridge. It's like organic food. You just put the word medical on whatever the item is and it's more expensive.
Right.
Um,
It's like $1,500 mini fridge with a
yeah, it's
padlock
like the
on
same
it.
fridge. Just write the word medical on it, medical grade. Historically, my practice, as I said earlier, I'm going to be very transparent. I'm kind of like very risk aversive, especially in pregnancy. And I feel like I'm maybe a little more gun shy than some of my other colleagues that I've run into in ASAM. So I've always kind of transitioned people classically back to the sublingual buprenorphine in pregnancy due to the limited safety data. I do think that this long-term efficacy of the methyl 2 pyrrolidone, it's really kind of under question. So it sounds like even after this trial, now there's an animal study showing that it possibly doesn't have an effect. We now have a trial here that at least you can use that the compound that's not containing that of depot buprenorphine. I would not be surprised if in 5 years, we just feel that this product is safe in pregnancy, to be quite frank. The
Yeah,
study
that's our
That's my
prediction.
prediction. I'm willing to put
Yeah.
$10 on it. Um, the study demonstrates improved illicit opioid absence during pregnancy with the extended release buprenorphine. And I love the fact that they have comparable infant safety data through the first year of life, because that's my big question. I really want to see that follow up. I don't think that the effect of the medication being more effective in pregnancy and it would really kind of changes my practice. It is interesting that there seems to be equivocal safety data in infants, and it kind of makes me a little bit more likely to consider this. So like while still not FDA approved in pregnancy, it does address a huge gap in our knowledge. I would like to use this in the future for like informed decision making with a patient. I don't think I'm ready to use a monthly depot, but would I consider a weekly depot? Possibly, if a patient really insisted on doing that. I'm not sure. What do you think?
Well, and even before this study came out, the product labeling for Brixadi said that you could consider it in pregnancy after a risk benefit, discussion with the
Yeah.
mom. So it wasn't totally off the table to start with, but it's nice to have some validation that it's totally safe. And this also gives you cover. You could like start it in pregnancy even. Before it was like if the mom is on it, if the person is on it and they get pregnant, then you have a risk benefit discussion about continuing. But this really supports initiating if that's what the patient wants, especially of the weekly dose. And I kind of suspect the monthly dose will be coming as well.
Yeah.
And then if you have that Sublocade, the other product, it's so long acting, even if you wanted to stop it in pregnancy, it doesn't really matter because it's so long acting, it'll probably be there for the whole duration of the pregnancy anyway.
Yeah.
Well, John, that was excellent. I really do think this is going to be a landmark trial in addiction medicine, especially of people who are pregnant. So thank you for presenting it. We got a little bit of talk back I wanted to share with our audience. We got some feedback on episode 73. If you remember, it was about how likely people are to continue opioids long term after their first opioid prescription. And the authors sent us an email answering some questions we had raised in the podcast. It was Dr. Martin and Dr. Smith. And the one that I thought was very interesting for the listeners was about tramadol. So if you remember, we had a lot of back and forth about tramadol, why that seemed to be particularly risky in terms of leading to long-term opioid use. Even though we often think of tramadol as like a safer opioid, it does have a higher rate of leading to long-term use. So maybe not so safe to start tramadol. And so what they said is, and it's a little bit long, so I'm going to read this quote for you. So we agree that painting the canvas on interpreting the potential effects of starting someone on tramadol, i.e. polypharmacy in a pill, and in turn higher likelihood of long-term opioid use is a complicated picture. To add a little more color, I like the extended metaphor here. To add a little more color on the tramadol picture, we would direct you to one of Dr. Martin's other works that examine the pattern of opioid use following tramadol, oxycodone, and hydrocodone sustained release more carefully. So they gave a link to his paper. So basically they said, if you look at figure 3, you'll see the pattern of continued opioid use following initiation by the 3 drugs. Like the study you covered, tramadol initiation conferred more long-term use and was less likely to rapidly discontinue opioids. What's interesting is that starting on tramadol does not necessarily mean you stayed on tramadol. The data show that of persistent tramadol users, 19% switched to another opioid, 6% switched to a long-acting opioid, and about 12% add another opioid on. So thinking through the risk of starting someone on tramadol also has to consider transition to other opioids, both short-acting and long-acting, in addition to long-term persistent tramadol use. So, John, have you seen that in your patients? Like if they start on tramadol, then they kind of transition to something else, another either short-acting or long-acting opioid? Or do you not, are you very good and don't prescribe long-term opioids?
I mean, I'm a rural country doc, man, dude. The idea that I'm not going to prescribe opioids, it's like I wouldn't have a job. I mean, I feel like, I think it's interesting. I think it's also just, I think it's hard to extrapolate anything because I feel like the background of this data has just evolved so much, right? I feel like 10 years ago, like when I started practice here, like there's so many like 30-year-olds on tramadol for like, SI joint pain from someone chronically or seronegative rheumatoid arthritis. And now I don't see a bunch of 30-year-olds just on tramadol for like pain NOS. I see a lot of people that are on tramadol now, like my older patients, which, viewing it as the least potent of the opioid options. I know there's a lot of polypharmacy there, but I don't see a lot of them switching. I don't know. It's hard. I mean, what's the other alternative then? Instead of like for your mild back pain, I'm going to give you oxycodone instead of tramadol. Is it a better option for someone? I don't know.
Yeah, I don't know either. I mean, yeah, I think the habit-forming nature is a harm, but I haven't seen a ton of like direct harm from tramadol itself.
I think it's definitely more habit forming in some regards. Definitely is an entry prescription opioid. Definitely, right? It is a gateway opioid, right? It is.
Oh my gosh. Well, all super interesting. We're about to be at 40 minutes, so I will sign us off. And I want to thank everyone for listening to the Addiction Medicine Journal Club. I really do think the best part of any journal club is the conversation, and I want to hear what you have to say. We both want comments. Please send them to us. You can email us. You can send us comments on social media. You can join our Facebook group. On Spotify, you can directly comment on the episode. YouTube, you can directly comment on the YouTube episode, so the links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. all patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.